If you've stopped accepting dinner invitations because you're not sure where the bathroom is, if you've started laying out a just-in-case change of clothes before family visits, if you've quietly given up on long car rides, long flights, or long anything, I want you to hear me very clearly. You are not broken. You are not getting old in a way you simply have to accept. And the small humiliations you've been quietly carrying for months or years, they are not your fault and they are not your sentence. Because here's what most people in that situation don't realize. This is not something you simply have to live with as part of getting older. There are specific, evidence-backed reasons it happens after 60, and concrete things you can do about it, starting today, without surgery, and without it taking over your life. My name is Dr. Matthew Reed, and today we are covering exactly that. What actually causes urinary incontinence after 60? What makes it worse every day without you realizing it? And the treatments that work, ranked from the simplest changes you can make tonight to the options worth discussing with your doctor. So if any of this sounds familiar, stay with me, because by the end of this video, you'll know exactly what's driving it and what to do next. Drop a comment right now and tell me, is this something you or someone close to you is dealing with? Just knowing you're here helps me make this better for you. What is urinary incontinence and why after 60? Let's start with what's actually happening inside your body, because understanding the mechanism is what separates people who manage this well from people who just suffer quietly. Your bladder is essentially a muscular bag. It stores urine, and when it's full, it sends a signal to your brain that says it's time. Your brain then coordinates a response. The muscle that holds your bladder closed, called the urethral sphincter, relaxes, and the bladder wall muscle, called the detrusor, contracts. Everything works together, and you make it to the bathroom in time. That coordination is elegant, and like most elegant systems in the body, it depends on a lot of moving parts working in sync. After 60, several of those parts begin to change simultaneously. And this is where most explanations stop being useful, because they treat incontinence as one thing, when it's actually several different things with different causes and very different solutions. The 4 types, and why the difference matters. Before we talk about what to do, you need to know which type you're dealing with. Because treating the wrong type the wrong way doesn't just fail, it can sometimes make things worse. Type 1. Stress incontinence. This is leaking that happens when pressure is placed on the bladder, a cough, a sneeze, a laugh, picking up something heavy, or even standing up quickly. It has nothing to do with emotional stress. The word stress here refers to physical pressure. The cause is a weakening of the pelvic floor muscles, the hammock of muscle that sits beneath your bladder and supports it from below. In women, childbirth, hormonal changes during menopause, and the natural loss of muscle mass with age all contribute to pelvic floor weakening. In men, prostate surgery is the most common trigger, though it can develop without any surgery history as well. When those muscles lose strength and tone, they can no longer maintain the closure pressure needed to keep urine in during moments of sudden physical stress. This is the most common type in women under 75. Type 2. Urge incontinence. This is the one most people describe as the sudden, overwhelming urge to urinate that arrives with almost no warning and doesn't give you enough time to reach the bathroom. Some people describe it as the key in the lock phenomenon. The moment you pull into your driveway or put your key in your front door, the urge hits like a wave. The cause here is an overactive detrusor muscle. Your bladder wall is contracting at the wrong times, sending false urgency signals to your brain before the bladder is actually full. After 60, the neurological signals between your bladder and brain become less precise. Small irritations, a change in temperature, the sound of running water, caffeine, alcohol can trigger involuntary contractions. This is the most common type in adults over 75. Type 3. Mixed incontinence. Exactly what it sounds like, a combination of both stress and urge incontinence occurring in the same person. This is actually more common than either type alone in women over 65. The treatment approach has to address both simultaneously, which is why getting a proper assessment matters so much. Type 4. Overflow incontinence. This one is less common but important not to miss. It happens when the bladder never fully empties. It fills, overfills, and then leaks continuously in small amounts. Unlike the other types, there's often no strong urge, just a constant, low-level dribble. The cause is usually an obstruction in men, most commonly an enlarged prostate blocking the urethra. In both sexes, it can also be caused by nerve damage from diabetes, spinal issues, or certain medications. This type requires medical evaluation because the underlying cause needs to be treated directly. If you're experiencing constant low-level leakage without urgency, Please speak to your doctor. Don't assume it's just aging. Why? It gets worse after 60. The real reasons. Now that you understand the types, let me walk you through the specific reasons why incontinence becomes more common and more severe after 60. Because these aren't just inevitable facts of aging, several of them are modifiable. Hormonal changes. In women, the drop in estrogen during and after menopause causes the tissues of the urethra and bladder to thin and lose elasticity. The urethral lining becomes more sensitive and less able to maintain a tight seal. This is one reason why incontinence often worsens significantly in the years immediately following menopause, then stabilizes, and why some women find meaningful improvement with localized estrogen therapy, something worth discussing specifically with your gynecologist or urologist. Muscle loss. After 60, the body loses muscle mass at an accelerating rate, a process called sarcopenia. This affects every muscle in your body, including the pelvic floor. Without deliberate training, these muscles weaken progressively, and the structural support they provide to the bladder and urethra diminishes with them. Bladder capacity decreases. The bladder itself becomes less elastic with age. It holds less before triggering urgency signals. A 3-5-year-old might comfortably hold 500 milliliters before feeling any urgency. A 7-0-year-old might feel urgency at 250. The bathroom doesn't need to be farther away. Your window of time simply gets shorter. Neurological slowing. The nerve signals coordinating bladder and brain communication slow with age. The warning that used to arrive with 10 comfortable minutes to spare now arrives with 2. That gap is where accidents happen. Medication effects. This is one of the most overlooked causes in older adults. Diuretics prescribed for blood pressure or heart conditions increase urine production. Alpha blockers for prostate conditions relax urethral muscles. Sedatives and sleep aids blunt the neurological signal that wakes you before you leak. Antihistamines affect bladder muscle function. If your incontinence worsened around the same time a medication was added, that connection deserves a conversation with your doctor. Chronic conditions. Diabetes causes nerve damage that disrupts bladder signaling. Parkinson's disease affects the neurological coordination of bladder control. Chronic constipation, more common after 60, puts sustained pressure on the bladder from the adjacent bowel. Treating these underlying conditions often produces meaningful improvement in incontinence, even without any bladder-specific treatment. What makes it worse every day, and what most people don't realize. Let me pause here because this section is where the most immediately actionable information lives. There are daily habits that are directly aggravating your bladder, and most people have no idea they're doing it. Caffeine, coffee, tea, energy drinks, many sodas. Caffeine is a direct bladder irritant. It increases urine production and triggers detrusor muscle contractions. If you have urge incontinence and you're drinking 3 cups of coffee a day, you are making it significantly worse every single morning. The research on reducing caffeine intake for urge incontinence is consistent and compelling. Not drinking enough water. This one surprises people every time. Many people with incontinence deliberately restrict their fluid intake, reasoning that less in means less out. The problem: concentrated urine is more irritating to the bladder wall than diluted urine. It actually triggers more urgency, not less. Mild dehydration makes the overactive bladder worse. The goal is consistent, moderate hydration throughout the day, not restriction. Drinking too much at once. The flip side: a large volume of fluid arriving at the bladder quickly overwhelms its capacity. Sipping steadily through the day is far better for bladder management than drinking a large glass of water all at once. Alcohol. A diuretic and a bladder irritant simultaneously. If evening incontinence or nighttime leakage is your primary concern, alcohol consumption in the hours before bed is one of the most direct contributing factors. Carbonated drinks. The carbonation itself, regardless of caffeine or alcohol content, is a bladder irritant for many people, sparkling water included. Artificial sweeteners. A lesser-known irritant, aspartame and saccharin in particular have been associated with bladder urgency in sensitive individuals. Constipation. The bowel and bladder share a neighborhood inside your pelvis. A full, impacted bowel physically crowds the bladder, reducing its capacity and increasing urgency. Chronic constipation is one of the most correctable contributors to incontinence that almost never gets addressed. What actually works? The evidence-based treatments. The options available are far better than most people realize. I'm going to walk you through them, starting with the single most important step you can take, and ending with the one most people wrongly assume they need first. 1. Pelvic floor physiotherapy. If there is one recommendation I want you to take from this entire video, it is this. See a pelvic floor physiotherapist before you accept incontinence as permanent. These are specialized physical therapists, trained specifically in assessing and treating the pelvic floor. They can identify whether your muscles are weak, tight, uncoordinated, or some combination. They can guide you through correct pelvic floor training, biofeedback techniques, and bladder retraining in a structured, personalized way. The results documented in research are consistently superior to self-directed exercise. A single assessment appointment can redirect months of effort that might otherwise be spent doing the wrong exercise incorrectly. Many people are embarrassed to make this appointment. I understand that. But pelvic floor physiotherapists spend every working day on this. There is nothing you will say or describe that will surprise them. And what waits on the other side of that appointment is often genuinely life-changing. 2. Dietary modification. We covered the irritants, eliminating them systematically one at a time, so you can identify which ones are your personal triggers is a low-cost, zero-side-effect intervention that produces meaningful results within days for many people. Start with caffeine. Cut it by half for 2 weeks and observe the difference. Then reevaluate. 3. Bladder training. This is the primary treatment for urge incontinence, and it is remarkably effective. The principle: your bladder has learned bad habits. It's been getting its way every time it sends an urgency signal, which has reinforced its tendency to send those signals too early and too intensely. Bladder training teaches it new habits. It works like this. You establish a fixed urination schedule every 90 minutes, for example, regardless of urgency. When urgency strikes between scheduled intervals, you use specific techniques to suppress the urge rather than immediately rushing to the bathroom. Those suppression techniques include stopping completely and standing still rather than rushing. Rushing increases intra-abdominal pressure and worsens urgency. Taking slow, deep breaths. Contracting your pelvic floor muscles deliberately, which reflexively signals the detrusor muscle to relax. Over weeks, you gradually extend the interval between voids from 90 minutes to 2 hours, then 2.5, working toward a comfortable 3 to 4 hour interval. Studies consistently show bladder training reduces urgency episodes by 50 to 80% in compliant patients. No medication required. 4. Pelvic floor muscle training. Kegel exercises. This is the single most evidence-supported home treatment for both stress and mixed incontinence, and it works for men and women. The pelvic floor muscles are the ones you contract when you're trying to stop urination midstream. That's the muscle group we're talking about. A landmark review in the Cochrane database, the gold standard of medical evidence synthesis, found that women who received pelvic floor muscle training were significantly more likely to report cure of incontinence than those who received no treatment. Similar results have been documented in men recovering from prostate surgery. The critical issue is technique. Most people who try Kegels and give up do so because they're doing them incorrectly, squeezing the wrong muscles, holding for too short a time, or not doing them consistently enough to see results. Here is the correct approach. Contract the pelvic floor muscles, not your abdomen, not your buttocks, not your thighs, and hold for 5 to 10 seconds. Then release completely for the same duration. That is 1 repetition. Work toward 3 sets of 10 repetitions daily. Results typically begin to appear within 6 to 12 weeks of consistent daily practice. Significant improvement is usually visible by 12 to 16 weeks. If you're unsure whether you're doing this correctly, a pelvic floor physiotherapist can guide you in a single session, and that guidance alone is often transformative. 5. Weight management. Excess abdominal weight increases intra-abdominal pressure, continuously placing constant downward force on the pelvic floor. Research published in the New England Journal of Medicine found that even a modest weight reduction of 5 to 10% of body weight produced a significant reduction in stress incontinence episodes in overweight women. The mechanism is direct and mechanical. Less pressure from above means less demand on the pelvic floor below. 6. Localized estrogen therapy for women. Distinct from systemic hormone replacement therapy, localized vaginal estrogen delivered as a cream, ring, or pessary acts locally on the urethral and vaginal tissues without significant systemic absorption. It rebuilds the tissue integrity that estrogen loss has degraded. Multiple studies have shown it reduces urgency, frequency, and stress leakage in postmenopausal women. It is considered safe even for many women who cannot use systemic hormones. This is a specific and direct conversation to have with your gynecologist or urogynecologist. 7. Medications. For urge incontinence specifically, a class of medications called antimuscarinics, including oxybutynin and tolterodine, reduce involuntary bladder contractions. A newer class called beta-3 agonists, mirabegron, is the most common, relaxes the bladder muscle with fewer side effects. These are legitimate tools, but I want to be direct. In older adults, antimuscarinics in particular come with a cognitive side effect profile that deserves serious attention. Dry mouth, constipation, blurred vision, and importantly, an association with cognitive impairment in long-term use in older adults. Before starting any bladder medication, have this specific conversation. Given my age and overall health, which medication has the best safety profile for me long-term? Beta-3 agonists are generally better tolerated in older adults and are worth asking about specifically. 8. When to consider surgery. Surgery is a real and sometimes appropriate option primarily for severe stress incontinence that has not responded to conservative treatment. Procedures like the mid-urethral sling for women and artificial urinary sphincter placement for men have strong evidence bases. But surgery should come after a genuine trial of conservative treatment, typically at least 3 to 6 months of consistent pelvic floor training and bladder retraining, not as a first response. If a surgeon recommends an immediate surgical solution without first discussing pelvic floor physiotherapy and bladder training, seek a second opinion. What to say to your doctor? Most people who see a doctor for incontinence leave with a prescription and very little else. Here's how to get more from that appointment. Say this: before we discuss medication, I'd like to understand which type of incontinence I have and whether pelvic floor physiotherapy and bladder training would be appropriate first-line options for me. Ask this: are any of my current medications potentially contributing to this and this? What lifestyle changes have the strongest evidence for my specific type? If your doctor dismisses these questions or moves immediately to medication without discussion, you are entitled to a referral to a urogynecologist or urologist who specializes in bladder dysfunction. This is a specialty with sophisticated assessment tools and a much fuller range of treatment options. Closing. Here's what I want you to take away from today. Urinary incontinence after 60 is common. It is not inevitable. It is not permanent. And it is absolutely not something you are supposed to quietly manage alone, cutting plans short, mapping every room for the nearest exit, and shrinking your life around a problem that has real, accessible solutions. The path forward almost always starts with the simplest steps: dietary changes, pelvic floor training, bladder retraining before it ever needs to involve medication or surgery. And a single appointment with a pelvic floor physiotherapist can do more in 1 hour than months of guessing on your own. If this video gave you something useful, a name for what you've been experiencing, a question to ask at your next appointment, or simply the knowledge that you are not alone in this, please hit the like button and share it with someone who needs to hear it. Leave a comment below. Have you been dealing with this silently, or have you found something that helped? Your experience in the comments might be exactly what someone else needs to read today. Subscribe if you haven't already, because next week I'm covering the 5 medications most commonly prescribed to adults over 60 that are now being reconsidered by leading geriatric specialists. You may be taking one of them right now. Take care of yourselves. I'm Dr. Matthew Reed. I'll see